Welcome back to the deep dive. And hey, if you're one of the amazing students powering through abnormal psychology at LACC with Professor Segi, seriously, congratulations, you've hit Module 11. That's the second to last deep dive for the whole semester. That is a huge achievement. You should really feel incredibly proud of the sheer amount of knowledge you've absorbed.
Oh, absolutely. It's definitely a marathon, not a sprint. And you are so close to that finish line now. And, for anyone who's looking at careers in nursing, social work, really any mental health field, this Module 11 on schizophrenia spectrum disorders, it's indispensable.
Yeah.
It covers arguably the most severe and complex conditions that we discuss in the whole course.
It really demands focus, and given how serious this topic is, our mission today is sort of to cut through that complexity in the module. We want to pull out the key diagnostic points, what we currently understand about why these conditions develop, the etiology, and really importantly, the full treatment picture. So you feel, ready to understand and crucially empathize with the immense struggles these conditions bring.
Exactly. We're aiming for clarity here, not just covering everything superficially. We'll distill down the essential concepts, what the spectrum actually is, why these disorders happen, and those critical clinical distinctions that help differentiate one diagnosis from another, which is vital.
Okay, let's unpack this. Before we get into the specific symptoms and all that, what's the big conceptual idea this module wants us to grasp right from the start?
The main framework is the spectrum. We absolutely have to understand we are not talking about just one single illness here. The schizophrenia spectrum covers a whole range of disorders. It starts with things like schizotypal personality disorder, with persistent social issues, eccentric behaviors, and it goes all the way up to the really severe, often highly debilitating conditions like schizophrenia itself, and also schizoaffective disorder. It's really a gradient, a scale of functional impairment that's tied to psychotic symptoms.
Okay, so focusing on schizophrenia proper then, the kind of core disorder in that spectrum. The module defines it by these major disturbances across thinking, perception, emotion, behavior. It's profound. We know the symptoms are severe. But what about that diagnostic timing, the 6-month requirement? Why is persistence so key diagnostically?
Right, that duration requirement, that symptoms have to be present for at least 6 months and they have to cause significant problems in social life or work. That's really the key predictor of prognosis. 6 months basically establishes that this is likely a persistent chronic illness. It helps distinguish it from, say, an acute psychotic break that might resolve more quickly. Clinically, it tells us, unfortunately, that the condition probably isn't going to just go away on its own. It needs long-term, often intensive management.
Huh. That really reframes that 6-month number. It's not just a fact to memorize for a test. It's a vital indicator for the future course. Okay, stepping back a bit. Why does this happen? The module points to genetics, environment, neurobiology. It's complex. But if you had to pick the most fundamental neurobiological concept for students to really get, what would it be?
Well, it's still largely rooted in the dopamine hypothesis, even though we now know it's much more complicated than we first thought. The neurobiological changes seem to point to dysfunctions in key neurotransmitter systems, and the hypothesis essentially suggests that an overactivity of dopamine, especially in certain brain pathways, is behind some of the most, striking features of the illness.
So if dopamine's overactive,
hmm
how does that actually translate into what the person experiences? What's the mechanism there?
That excess dopamine activity is strongly linked to what we call the positive symptoms. That feeling of being flooded with information, misinterpreting things is highly significant. The really intense reality-bending nature of delusions and hallucinations. Basically, the brain might be generating too much signal noise, you could say, which the person then experiences as if it's coming from the outside world, as this pressing reality.
Let's talk about those symptoms then, starting with the positive ones, the ones that are sort of added to normal experience. The most well-known is probably the delusion, this persistent false belief, totally fixed, even when there's clear evidence against it. What's the one key distinction about delusions that every future clinician absolutely needs to nail down?
It has to be the difference between bizarre and non-bizarre delusions. Making that distinction is really crucial for accurate diagnosis. See, non-bizarre delusions are about situations that, while false for the individual, are technically possible, like believing the FBI is secretly following you. It's almost certainly not true, but it could theoretically happen.
Right. But a bizarre delusion is something that's just fundamentally impossible within the person's cultural context. Can you give us a strong example from the module?
Oh, sure. A classic example of a bizarre delusion would be something like thought insertion or thought broadcasting. The absolute fixed belief that, say, aliens are putting thoughts directly into your head, or that everyone on the bus can hear your private thoughts because they're being beamed out like a radio signal. That kind of phenomenon just cannot happen in our shared reality, and when you see that, it strongly points towards a schizophrenia diagnosis.
Okay, so delusions are these fixed false beliefs. Then hallucinations are false perceptions, experiencing something sensorially when there's no external stimulus, like auditory hallucinations, hearing voices, which you mentioned are the most common type. Beyond these really striking positive symptoms, what are the other core areas of disturbance?
Well, we also see disorganized thinking, which usually shows up as disjointed, incoherent speech. It's hard to follow their train of thought. And then there's disorganized or abnormal motor behavior. This can range from really unusual movements or odd posturing, all the way to a significant decrease in reactivity, which we call catatonic behavior, or even stupor. But, and this is critical, we absolutely have to talk about the negative symptoms.
Right. Why are those negative symptoms often considered the bigger clinical challenge in the long run, even though they might seem subtler than, say, hearing voices?
Yeah, they are subtler but often more debilitating. It's because they represent a decrease or even an absence of normal functions. Things like having a really flat, affect and expressionless face, or avolition, a profound lack of motivation to do anything, or alogia, significantly reduced speech. These negative symptoms tend to be highly resistant to our current medications, unfortunately, and they often cause the greatest long-term functional impairment. They make it incredibly difficult for the person to hold down a job, maintain relationships, sometimes even just to manage basic daily activities like getting dressed or preparing food.
That really highlights the complexity. And it brings us nicely to the rest of the spectrum, right? Where the main differences between disorders often come down to duration and the specific combination of symptoms. This seems like where diagnostic accuracy becomes absolutely critical for getting the treatment plan right.
Exactly. This is the stuff future practitioners really need to internalize. So if we look at delusional disorder, for instance, here someone has one or more delusions for at least a month, but, and this is key, their day-to-day functioning, apart from the impact of the delusion itself, is mostly okay. Their behavior isn't generally bizarre or obviously odd. The delusion is the main event.
Okay. And then you have the short-term episodes, the crises. If someone suddenly develops full-blown psychotic symptoms, but they only last from, say, one day up to less than a month, often after some major stress, that's different again.
That's brief psychotic disorder. It can sometimes be called brief reactive psychosis because it often follows a significant stressor. And the module also notes a specific type, brief psychotic disorder with postpartum onset, which occurs within about 4 weeks after giving birth. It's sudden, intense, but crucially short-lived.
Right. Now, what if someone does meet all the symptom criteria for schizophrenia? They had the delusions, hallucinations, maybe negative symptoms, but it's only been going on for, say, 3 months, not the full 6.
That's where schizophreniform disorder comes in. It's essentially like a provisional diagnosis. The symptoms are there, they've lasted for at least a month, so it's significant, but they haven't yet hit that crucial 6-month mark required for a full schizophrenia diagnosis. So we use schizophreniform and then we basically wait and see. Will it resolve within the 6 months or will it unfortunately progress into schizophrenia?
Okay, that makes sense. The final piece in this diagnostic puzzle, the one that often seems to trip people up, is schizoaffective disorder. Why is that one considered so complicated to diagnose correctly?
It is complex. It's tricky because it involves having both the persistent psychotic symptoms of schizophrenia and significant mood disorder symptoms, either major depression or mania happening concurrently. But here's the crucial rule. The thing that separates it from just being, say, bipolar disorder with psychotic features or major depression with psychotic features, the psychotic symptoms, like delusions or hallucinations, must be present for at least 2 weeks on their own without a major mood episode happening at the same time. If the psychosis only occurs during the depressive or manic episodes, then it's diagnosed as a mood disorder with psychotic features. If the psychosis continues even when the mood is relatively stable, that points towards schizoaffective disorder.
And 2-week independent period is the key differentiator.
Okay.
And before we jump into treatment, we have to quickly mention the external triggers, right? Substance medication-induced psychotic disorder, or SIPD. This is where psychosis is directly linked to using drug stimulants. Hallucinogens are common culprits, or sometimes withdrawal from medication. This seems like a growing issue clinically.
It absolutely is. And the primary treatment goal there is straightforward, at least in theory. Stop the substance use. It's a critical reminder that environmental factors, external chemistry, can absolutely mimic these severe underlying illnesses, which just underscores why taking a really thorough medical and substance use history is non-negotiable during any assessment for psychosis.
All right. Here's where it gets really interesting. Given the complex biology, the potential for neurotransmitter issues, and the often poor functional outcomes, especially with negative symptoms, how does the field approach treatment? Is it just about medication?
Definitely not just medication, though meds are foundational. Treatment really has to be multifaceted. Antipsychotic medications are typically the first line and essential for managing the illness. They work primarily by blocking dopamine receptors, as we discussed, and they are generally quite effective, sometimes dramatically so, at reducing those acute positive symptoms, the hallucinations, the delusions, the disorganized thinking.
But as you mentioned earlier, their effect on negative symptoms can be pretty variable, sometimes minimal. And the side effects, things like weight gain, metabolic problems, sometimes movement disorders, can be really challenging and often lead to people stopping their medication. So we absolutely need the psychosocial tools too. What are the key non-pharmacological therapies the module points to?
Yeah, the psychosocial interventions are vital for long-term recovery and functioning. We rely heavily on things like cognitive behavioral therapy or CBT. CBT for psychosis focuses specifically on helping people develop coping strategies for symptoms that might persist even with medication, and also works on modifying some of the dysfunctional beliefs. And then there's social skills training, SST. This is incredibly practical, aimed at helping patients navigate everyday social situations, improve communication, and hopefully increase their social engagement and reduce isolation.
And the module specifically calls out one therapy designed to tackle those cognitive deficits that often accompany schizophrenia, right? The problems with memory, attention, executive function.
That's right. That would be cognitive enhancement therapy, or CET. It's a pretty structured, evidence-based intervention. And it's designed not just to manage symptoms, but specifically to improve cognitive function, social cognition, understanding social cues. And there's even some evidence suggesting it might help protect against gray matter loss in the brain over time. When you combine these psychosocial therapies with appropriate medication, the chances for meaningful functional recovery improve significantly.
Wow, okay. So we've covered a lot of ground here. From understanding that crucial 6-month diagnostic window for schizophrenia to differentiating it from the shorter duration disorders like brief psychotic or schizophreniform, and outlining this comprehensive treatment toolbox that absolutely has to address both positive and negative symptoms using meds and therapy.
Exactly. And if we connect this back to the bigger picture for the students listening, honestly, the level of nuance you've hopefully absorbed today is critical. Knowing the clinical difference between a non-bizarre delusion and a bizarre one, or truly understanding why schizoaffective disorder needs that 2-week period of psychosis without mood symptoms. That kind of detailed understanding can literally be the difference between a misdiagnosis and getting someone started on the correct, potentially life-stabilizing treatment plan. This level of detail really matters for your future practice.
So what does this all mean for you, the student, listening right now, almost at the end of this incredibly demanding course?
I think it means that really internalizing this material does more than just prepare you for an exam. It fosters a deep, genuine understanding and hopefully compassion for individuals navigating these incredibly severe mental illnesses. And honestly, having that empathy, working actively to avoid stigma, that's probably the single most crucial attribute for anyone going to healthcare or mental health, especially when working with the often vulnerable populations affected by the schizophrenia spectrum.
That's a powerful point to end on. And maybe just one final thought for you, the listener, to mull over as you finish up your studies. Consider that sociocultural perspective the module touches on. It suggests that things like cultural context and environmental conditions can influence not only who develops these disorders, but also how they're perceived and treated. So, if things like early identification of environmental stressors or addressing social determinants of health could be key for intervention, what does that imply about the changes we might need in broader public health policy, both locally and globally? How do we ensure equitable access to sensitive, effective care for those most at risk wherever they are? That's a big question, but definitely one worth thinking about long after the course ends.